Good morning, everybody. Welcome back to the regular webinar. Today we have a very important topic and very important person to deliver the lecture. All of you might know Dr. Smitha Prabhu. If you are active in IADVL circles, if not, be active in IADVL circle and get the taste of our organization and capacities. Anyway, she is presently the head of department of the prestigious Kasturba Medical College, Manipal. And she is a versatile personality. I know her from very early time. And when that time, she was very keen on contact dermatitis. Now, she is keen on contact dermatitis, but the present interest is in psychodermatology. And they are running a very beautiful clinic in the department of psychodermatology, which is not very common among the dermatologists, dermatology training in various other medical colleges. So we decided to invite her to share her experience in psychodermatology and to kindle interest in psychodermatology among the PG trainees in dermatology. So welcome, Dr. Smitha Prabhu. Over to you.
Thank you, Crichton, sir. I am honored to be here. And thank you, East West Pharma and all the organizers. Without much delay, I'll be starting the talk. Let me share my slide. So this is just an overview. There is much more to psychodermatology. So what is psychodermatology? It is a subspecialty of dermatology which deals with the disorders affecting the psyche, that is the mind and skin. It is said that up to 40% of dermatology patients have some psychological or psychiatric comorbidity or the others. Very often we fail to recognize those. So let us see what is the definition. It is a branch of dermatology which deals with either primary skin diseases which are associated with psychosocial morbidity, that is chronic and disfiguring conditions like vitiligo, psoriasis, leprosy, atopic dermatitis, or even severe acne. I can't name all these are too many. As well as psychiatric disorders, which are primary psychiatric disorders which should be treated by the psychiatrist, but which end up with us because of their dermatological findings like dysmorphophobia and delusional parasitosis. So before coming into the disease proper, something about the pathomechanism. Just remember this word NICE, N-I-C-E. That is neuroimmunocutaneous endocrine system, because all these are interconnected. Skin and nervous system, as we all know, developed from the same ectoderm in the embryo. Skin is an active neuroimmunoendocrine interface. So what happens? Stimuli received from the skin can influence immune, endocrine, and nervous systems and otherwise. And the brain can modulate inflammation in the skin. So it is a two-way road. This diagram explains it all. So you can see when there is stress, HPA axis gets activated. Th2 response becomes very robust. That is, humoral cell immunity gets activated. B cell, eosinophils, and mast cells produce the inflammation, whereas cell-mediated immunity is suppressed. The anti-inflammatory cytokines are suppressed and inflammation sets in. And if bacterial infection of the skin occurs, interleukin 1 and 6 are produced by the antigen-presenting cells, which can cause inflammation in the brain. We will go further. This is it in a nutshell. Stress can cause sympathetic activation as well as HPA activation, producing steroids, epinephrine and norepinephrine, which can dampen the CMI and promote humoral response, leading to inflammation. Acute stress is fine. Normal stress response leads to cortisol release, which blocks the inflammation. But what happens when there is chronic stress? Recurrent and chronic stress leads to chronic and high cortisol release, which leads to cortisol resistance. And then this physical stress has an effect on the brain, leading to inflammation of the brain. So chronic stress reduces immunity. It can disturb the epidermal permeability barrier homeostasis. It can liberate histamine, vasoactive neuropeptide. It can cause hemodynamic related changes, leading to changes in skin temperature, blood flow, and sweat responses. All this can lead to increased pruritus. That is why people develop increased itching when they are stressed out or anxious. So we'll stop about the pathogenesis there. That is pathogenesis in a nutshell. Now let's see about the psychodermatological disorders. There have been many classifications since the early classification by Ku et al. In 2003. But this is the simplest and best to remember. So I would like you all to remember this. Many other classifications have come up. I'll show the latest also, but this is the easiest to remember. Here they have divided it into primary psychiatric disorders, that is disorders of belief and delusion, like delusion of parasitosis, body dysmorphophobia, venereophobia, and factitious dermatosis. And then there is secondary psychiatric. That is, initially it is a cutaneous disorder, later it affects the psyche. Like disfiguring conditions, mostly acne, vitiligo, psoriasis, severe atopy, which all cause stress as well as depression. Then there is something called as psychophysiologic, that is diseases which are precipitated by stress. Here again there is psoriasis, acne, alopecia areata, vitiligo, atopy, etc. So you can see that secondary psychiatric and psychophysiologic can have an overlap. Same disease can be there in secondary psychiatric as well as psychophysiologic. Finally, there is a miscellaneous group, which is mostly cutaneous sensory syndromes like vulvodynia, penodynia, glossodynia, as well as skin cutting disorders, suicidal intention, and many other unnamed disorders like eating disorders, which have skin findings. I'm not going into eating disorders and all today. I thought I'll focus on the other common diseases. So the same psychodermatological, which are the primary psychiatric, that is psychiatric disorders with dermatological symptoms. It's mostly what we see are trichotillomania, delusion of parasitosis, and body dysmorphophobia. Secondary psychiatric would be alopecia, psoriasis, vitiligo. Psychophysiologic, there is a large group, alopecia, acne, rosacea. You know that whenever the person is stressed out or angry, rosacea can flare up, urticaria, atopy, psoriasis, then finally the miscellaneous group, cutaneous sensory syndrome, even psychogenic purpura, called as Gardner-Diamond syndrome. This is the newest classification, slightly confusing. Here they have divided into two broad subsets. That is primary mental health disease affecting the skin and primary skin disease linked with mental health. In primary mental disease affecting the skin, they again have divided it into with visible skin lesion, without visible skin lesion. Again, in primary skin disease, they have divided into with visible skin lesion and with or without visible skin lesion. And this is the classification. I feel this is mostly for those very well into psychodermatology. Even if you don't remember or you are confused, it is fine. If you want to read further, this is the reference. So here, primary skin disease, mental disease with skin lesions. They have mostly classified it as delusional disorder like parasitic infestation, delusional infestation, and then obsessive disorder like body dysmorphophobia. And without skin lesions, it is all those burning syndromes, burning mouth, burning vulvodynia, all those. And then again, primary skin disease with or without skin lesions. So I am going in this with this classification, the older classification. So let us see the individual diseases. Primary psychiatric, often difficult to treat, and psychiatric consultation is very well preferred. But the problem is that these patients think this is a skin condition and they don't like to go to psychiatrists. So a very good rapport is required. And it's often at the third or fourth or a later time when we can refer to the psychiatrist. These mainly include disorders of obsession like BDD, venereophobia, disorders of compulsion like trichotillomania, onychophagia, skin picking, delusional parasitosis, and trichotillomania are common things which we see in OPD. So primary psychiatric are usually factitious or self-inflicted, can be delusions or hallucinations, can be somatoform diseases, and can be compulsive disorders. So which are the factitious disorders? You all may have encountered dermatitis artifacta or para artifacta. We'll come to it later. Malingering, we'll see what is the difference between all these. Then special forms like Munchausen's by proxy, and Gardner diamond. Delusions like delusion of parasitosis, delusion of bromhidrosis, and body dysmorphophobia. Somatoform, that is mind influencing the body, like cutaneous dysesthesia, cutaneous sensory disorder. If you remember my classification, this cutaneous sensory disorder I classified as miscellaneous also. Some people classify it as primary psychiatric also. So there is some area of grayness here. And functional disorders. Then finally, compulsion. A compulse to scratch, a compulse to hand wash, or a compulsion to pick the skin or nails. We'll come to diseases one by one. So delusion of parasitosis, it is also called as Ekbom disease. It was first described in as far as 1894 by the French dermatologist Thibault. In psychiatrist's term, it is called as monosymptomatic hypochondriacal psychosis. Only one symptom is there. So it's monosymptomatic. They have a firm, fixed belief. They can't be taken off that belief that they are infested by parasites, mites or lice. They would have sought repeated treatment, repeated consultation, no satisfaction. They would have even had repeated de-infestation of their houses, surroundings to no avail. These people come to us with intolerable itching and dysesthesia. Patient is often distressed. They would have scratched themselves to cause lichenification and excoriation. Sometimes there is a shared delusion, which is called as folly edu, that is folly of two, or folly a family. Recently, that is 2 years ago, we saw a case of folly a family involving the primary case of a mother. Later, it was spread to her 2 children also, that they were all infested with mites. It is of insidious onset. At first, people may think it's real infestation. Slowly it progresses. It's a chronic course. It is not satisfactorily treated. Obsessive cleansing schedules are there, and the typical matchbox sign is displayed. Patient may bring skin debris or dirt in matchboxes of paper towels, saying it is the mite. Always rule out differentials. Never sort of label the patient as delusional before ruling out other possibilities. Sometimes it can be a real infestation. Even vitamin B12 deficiency can lead to paresthesia. Pellagra can cause hepatic and renal failure, severe diabetes, multiple sclerosis is something which we don't think of. And leprosy is also mentioned in literature as to causing paresthesia. So be diligent to rule out differentials. This is one of our patients. She is demonstrating the sign. She had delusion involved the scalp wound. So she's saying she's infested by something on her scalp. She has undergone repeated treatment. So she was referred to a psychodermatology clinic and she was started on SSRIs. So difficult to convince the patient otherwise. Psychodermatology liaison will be helpful, but they often don't agree to go to psychiatrists. We may have to bring the psychiatrist to them. So sometimes in a primary care setup, or if psychiatrist is not available, we may have to learn to treat the patient. But remember that all these atypical antipsychotics have their own side effects. Earlier, pymoside was the drug of choice, but nowadays, because of its very severe side effects, it is not very much preferred. So risperidone, olanzapine, or aripiprazole are the drug of choice. The dictum in psychodermatology treatment is start slow and slowly increase, and stop and refer to a psychiatrist if you feel the patient is not responding or if side effects occur. Most side effects are extrapyramidal side effects. So these are the doses. This is a very interesting disease. I have not seen it so far. It's there in textbooks. A very rare variant of delusion of parasitosis, where the patient feels fibers are extruding out of skin or from ulcers or sores, accompanied by stinging, crawling, or burning sensation, called as Morgellon disease. Coming to the next primary psychiatric syndrome, body dysmorphophobia. It is said that adolescents have it to some extent. Most of us in our formative years will have some sort of body dysmorphophobia, not very high. This is delusion preoccupying on a single or multiple body part. What is it? Preoccupation with a minor or imagined defect in a body part, which often seems insignificant or invisible to others. We may feel they are perfect, but they feel their nose is too big, or acne is too severe, or face is too red. It's usually seen in women, young to middle-aged women, but men are also not exempt. Area of concern is usually face, especially nose, acne, open pores, hair, thinness of hair, or dryness of hair, breasts in female, genitalia in male, and body weight in female and muscles in male. So weight, facial, and breast concerns is more in females, whereas size of genitalia and musculature concern is more in males. See, the woman looks normal, but this is how she perceives herself. There'll be associated compulsive behavior. They'll try to camouflage the undesirable part with clothing, cap, mask. There'll be frequent mirror checking. They'll even while walking, they'll be checking at shop windows and everywhere to see whether they are looking good. They'll repeatedly seek reassurance. Even if they're reassured, they won't accept the reassurance. There's impaired social and academic functioning. They are cosmetic surgery seekers and they are frequent litigators. So nowadays, many cosmetic surgery clinics have this body dysmorphophobia checklist. I have not put the checklist or the DSM BDD grading here because there is lack of time, and this is just an overview. You can read about it later if you want. Differentials you should rule out. Sometimes OCD, social anxiety disorder, body-focused repetitive behavior, eating disorder, schizophrenia, or dysmorphic concern. All these can mimic body dysmorphophobia. again treatment is difficult. Psychoeducation, cognitive behavior therapy, along with medication is required. Serotonin reuptake inhibitors and selective serotonin reuptake inhibitors are used. Fluoxetine, fluoxamine, paroxetine, citalopram, sertraline, all these are used in high dosage. If patient refuses psychiatric help because they also feel they don't have a psychiatric disease, we ourselves may have to start, but always be on the watch out for suicidal risk, side effects, and non-improvement. Because we are primarily not psychiatrists, we may miss the small clues. Now coming to self-inflicted lesions in dermatology, these are of two types: with hidden or denied underlying behavior or without any hidden behavior. That is, first one is patient doesn't accept that they are doing it. Second one, patient accepts that they are doing it. So with hidden behavior, you have one with external incentive, like malingering. That may be a child saying they have some skin lesion to go and refusing to go to school, or a person saying hand dermatitis and refusing to go to work. No external incentive is factitious disorder and Munchausen in dermatology. Without hidden, which is not denied, is skin picking related skin damage syndromes like acne, excoriae, trichotillomania, onychophagia, that is nail biting and nail eating, skin cutting, skin burning, scarification. Nowadays, these body modifying disorders are also there, like extensive tattooing and piercing of the body, more than normal. 1 or 2 tattoos or piercing are not in this realm, but more than 10, more than 20 everywhere. And repeated seeking of aesthetic treatments and complications thereof. Let us see about factitial dermatosis. This refers to a psychiatric condition where there is deliberate and conscious production of self-inflicted lesions to satisfy an unconscious need. It may be a psychological need or an emotional need. Lots of synonyms: artifacta, simulata, or feigned dermatitis. It is seen in childhood, late childhood to early adulthood. Here also females predominate. In most of these cases, females predominate because from time immemorial, females have been suppressed from expressing their emotions. They can't throw tantrums. So the body becomes the canvas for expressing their desires or their distrust or whatever. There is no racial or ethnic predisposition. Multifactorial etiology, there is a genetic predisposition. Associated psychiatric illnesses may be there, like anxiety, depression, dysthymia. Dysthymia means low-grade depression, not amounting to clinical depression. Dysmorphophobia may be associated. Neuropsychological trauma is known to play a role, that is child abuse or sexual abuse in childhood, post-traumatic stress disorder due to loss of a parent. Personality disorder may be there, like attention seeking, obsession, compulsion. Psychosocial factor like poor coping mechanism in school or family, poor social support. All these can play a role. So these are whatever I told. Along with that, eating disorders may be associated in approximately 1/3 of cases. So if you suspect this feigned dermatosis, you have to ask about all this, but not in a direct manner. Hollow history is a very important diagnostic clue. All PGs are taught that you have to take a very good history. You have to ask about the story of the lesion, evolution of the lesion, morphology of the lesion, story of an individual lesion and the disease as a whole. You just point out to a lesion and ask how it evolved. How was it? How many days ago it happened? How did it become this big, or how did it become like this? If the patient is able to say coherently, well and good. If not, it is a diagnostic clue. And typical lack of concern. The lesion may look, it may be a large ulcer extruding pus, but the patient may be sitting with an indifferent expression. This is called as la belle indifference. Belle because it's often a female. Lesions at accessible site. And bizarre lesions, irregular, jagged, linear, geographic outlines. It may not resemble anything in the dermatology textbook, any disease. Look for absence of other diseases to explain the lesion. Sometimes you may resort to a biopsy, but biopsy may not show any typical pathology consistent with clinical finding. So all these are diagnostic clues. So accessible site, sharp demarcated geographic borders is a clue. These people are very clever. They produce sophisticated and ingenious methods of causing lesions. Serious complications may occur because they keep on causing the lesions. They don't give care to the lesions. So gangrene, abscess formation, secondary infection, all these can occur. Nearly 3/4 people have only one type of lesion, but few may have two or more morphological types. And in 2/3 of people, only one body segment is involved, like one hand or one leg. But in 1/3 people, multiple body areas may be involved. So face is the most commonly involved. Then comes hands, lower extremity, trunk, upper arm, and scalp is not commonly involved. So these are various types of lesions caused. Any sort of lesions may occur. Excoriation, erosion, pigmentation, irritation, you name it, you have it. Any way it can be produced. By rubbing, scratching, biting, injecting, exposing to heat, cold, even injecting urine and feces is known in literature. This is one of our patients. Initially, she was diagnosed as aborted Stevens-Johnson syndrome or fixed drug reaction, or even excessive lip biting, vasculitis. Finally, we put the diagnosis of dermatitis artifacta. She was always smiling, refusing to take. She had eating disorder also. 17-year-old girl. She's from Kerala, very intelligent. She's actually a psychology student and very hollow history. Parents were fed up with her. Seems she has issues with her parents also. But we could never make out how she caused the lesions. It looks too sophisticated for a simple lip bite. This is a special type of dermatitis artifacta, Charcot's edema or Secretan syndrome. Henry Secretan described it, factitious edema of the hand caused by frequent application of tourniquet or even by repeated hitting across a hard surface. It would be chronic and recurrent, and after some time, progressive fibrosis of the injured tissue leads to edema of the dorsi of hands. So there are many differentials, genuine skin disease, factitious disease caused by others like abuse, fabricated or induced illness, Munchausen by proxy, where mother brings the child because mother wants attention, mother or caretaker, usually it's the mothers. And other self-inflicted lesions like excoriations, lip licking, nail biting, trichotillomania, self-harm during episodes of stress, dermatitis neglecta. All these can come into factitious disorders. Sometimes you may mistake pyoderma gangrenosum or ecchymosis related to hematological disease to be factitial dermatitis or vice versa. What is malingering? Malingering is deliberate creation for secondary gain. It is not a mental illness. It is just that the patient is too clever. In factitious dermatitis, there is no obvious secondary gain. Everything is in the psyche of the patient. They do not admit to causing lesions, and it is a mental illness. Munchausen's by proxy, caregiver makes up the injury or really injures the child. Often the child is physically harmed to gain sympathy and material needs. This is to be suspected when a child is repeatedly brought with unusual dermatosis and only the same person brings the child and the bystander is unusually uninvolved, almost serene and happy, and sometimes another child would have suffered the same or even had a death. I have not seen such a case, but this is reported very often in literature. There is something called as para-artifacta. There is a condition and the condition is exacerbated. That is tampering with a disease, impulse control disease. It may be conscious or semi-conscious tampering with the existing lesion, like acne, excoriation, neurotic excoriation, or if a psoriatic lesion is there, repeatedly trying to pick at the lesion. All these are para-artifactas. There is no specific workup. Skin biopsy can be done to rule out other causes. Observation of the unaware person is the best diagnostic method. There is a case report in literature, an Indian study where they observed the patient under CCTV and caught them causing the lesion. Histopathology depends on how the injury was caused. It is said that telangiectasia of vessels in the dermis may be a clue to dermatitis artifacta. It has been reported as a response to persistent local trauma. Otherwise, the histopathological findings mimic the injury caused. So what is treatment? It is very challenging. First, you treat the condition or you treat the lesion. Topical bland emollients, antibiotics, epithelializing agents, antihistaminics if there is itching. Keep the lesion under a bandage so that patient can't again excoriate or cause harm. Psychiatric consultation is a must. Selective SSRIs are given like paroxetine, sertraline, citalopram, or tricyclic antidepressants like doxepin, amitriptyline, or typical and atypical antipsychotics. Psychotherapy can be tried like psychoeducation, relaxation techniques, cognitive behavior therapy, and aversion therapy, but it often fails. Coming to body-focused repetitive behaviors or BFRBs are slightly more common than the previous diseases which I discussed so far. Characterized by self-grooming routines that essentially go overboard. We all cut our nails, comb our hair, keep ourselves clean. This involves pulling, picking, biting, or scraping at one's own hair, skin, or nail. Trichotillomania, dermatotillomania, onychophagia, all this come under this group. Prevalence is 3%. Related to anxiety, impulse control, and OCD. Nowadays, a new entities there which are not put here. Plucking of facial hair using tweezers is also coming in this. N-acetylcysteine role is asked. I'll be elaborating it in trichotillomania. So this has genetic component. It starts towards late childhood, more in females. Behavior therapy is worth more than medications in these cases. SSRIs, clomipramine, naltrexone, and olanzapine may be used. This is courtesy to Dr. Abdul Latif. He has shown obsessive. This is very difficult. Usually people bite hand, fingernails. This is toenail biting. And this is excessive lip biting shown here. This is one of my patients. He was diagnosed as cheilitis and treated for cheilitis repeatedly. He is an MBBS student. He used to come repeatedly. He refused lip licking whenever we asked, but we could observe him licking the lips. And he used to come with repeated impetigo. You can see impetiginization at the edges. We would treat him with steroid antibiotic cream, oral antibiotics, give Vaseline, all that. He would come repeatedly. So finally, we have diagnosed him as exfoliative cheilitis. This exfoliative cheilitis, in 65 to 70% of cases, they have a psychologic basis. But he refused psychodermatology evaluation and is not agreeing to accept that this may have a stress background or psychodermatological background. So we are just treating him empirically. And in medical students or people with medical background, it is very difficult to treat psychodermatological conditions unless they agree. Another girl, 14-year-old girl, you can look at her nails. This is a nail tick disorder. She has caused these red striations of furrows in the middle of the nail. Along with it, you can see bleeding from the nail folds. Trichotillomania is relatively common. Hair pulling disorder involving frequent, repeated, uncontrollable urge to pull the hair from scalp and sometimes even other parts of the body. It comes under OCD spectrum, that is obsessive compulsive disorder, seen mostly in adolescents and children, but occasionally in adults. There are various scales to assess the severity. I'm not going into that. You should also know about trichotillomania, where there occurs rubbing of hair and scalp. Sometimes they rub the hair together, or sometimes they rub the hair onto the scalp. If it is onto the scalp, damage to the scalp is more. Then trichotillomania, which means cutting of hair. Trichobezoar occurs in up to 20%, where they swallow the pulled hair, which is a dangerous condition because hairball can form, which can lead to gastric obstruction. On the right hand side, which I've taken from the internet, is a hairball in the shape of the stomach. So it is supposed to be a cry for help. What are the triggers? There is a sensory trigger, that is hair thickness. They pull only hair of certain thickness, certain length, and certain location. Sometimes physical sensation on the scalp is a trigger. Many people say they develop some itching or some weird sensation on the scalp before pulling. Emotional triggers. In certain situations only they pull. While studying or while encountering certain people, when they are bored, tense, or angry. And there is a cognitive trigger. When they think about their hair and appearance, in people with rigid thinking, with cognitive errors, etc. Sometimes it is an automatic pulling. They never know when they pull. So automatic pulling is versus focused pulling when they know when they pull. Complicated pathophysiology, something to do with gray matter. Density of gray matter is affected in caudate, putamen, and amygdalo-hippocampal area. It is said that high cerebral glucose metabolic rates in the cerebellum and right parietal cortex may be having a role. That is why N-acetylcysteine has a role here. This is one of our patients. Actually, we have pulled up her hair to show this. If her hair is down, we can't even make out she has hair loss. She was a 16-year-old girl with trichotillomania. She had multiple stressors, studies, some parental disharmony, all that. There are various diagnostic criteria. This is DSM diagnostic criteria. That is recurrent hair pulling leading to hair loss, repeated attempts to decrease the hair loss by the patient. It causes significant distress or impairment in various areas of life, like social, occupational, and other important areas of functioning. And the hair loss is not attributable to other medical conditions like alopecia areata. And it is not better explained by any other mental disorder. Complications can be psychological. The lost hair itself can lead to anxiety, low esteem, psychosocial dysfunction. Quality of life is low in 1/3. Trichophagia, as I told earlier, persistent alopecia may occur. and depression, anxiety, and even substance abuse is associated. Diagnosis, we have dermoscopy here. First, rule out other causes, though clinically also we can diagnose hair of varying length, accessible parts. Of course, whole area of the scalp is accessible, but to a right-handed person, it would be usually the right temporal area of the vertex and so on. Alopecia areata will have a different appearance, and dermoscopy is very characteristic. You can see broken hair, coiled hair, flame hair, V sign, tulip hair and hair powder, and even signs of hemorrhage. Histopathology will show trichomalacia or distorted hair shaft and perifollicular hemorrhage. All these are from the net, not my own pictures. Management, elicit the cause and neutralize it. If it is in a child, mostly it is the birth of a new sibling or conflict with teachers or peers or parental conflict. If it is an adult, work stress, stress of studies, all that. Behavior therapy plays a very good role. Habit reversal or cognitive behavior therapy can be tried. SSRIs and N-acetylcysteine, which works with the glutamate pathway, can be tried. N-acetylcysteine we have tried in our PD clinic. It doesn't have a very dramatic response, but we do try 1200 mg in adolescents and up to 1800 in older people. It's a bit expensive. Habit reversal, that is, identify when and where the urge occurs, teach relaxation during those circumstances, and develop a competing response like making a fist. In our PD clinic, one child was given a doll with long hair, and she was told to pull hair from the doll when she felt like pulling her hair. But problem is that the doll can't be carried everywhere. So this is the nutshell of cognitive behavior therapy, controlling thoughts, emotion, behavior, which goes into the physical sensation. This is one of a patient's very resistant lichen simplex chronicus. She didn't have a primary disease. She herself induced these lesions. She's even been put on cyclosporin. Only cyclosporin works in a case. She's on high dose mirtazapine, more than 15 mg. Even psychiatric people have almost failed in her case. She has got lots of interpersonal and depression and other psychiatric issues. So we finished with primary psychiatric. Secondary psychiatric, here the disease leads to disfigurement, which causes anxiety, depression, social phobia, and psychosociosexual relationship problems. For example, a youngster with extensive vitiligo may not find a partner or may have problems facing others or facing job situation, especially if they have it in areas like face and hands. They may not get job in hospitality industries. Here, counseling, psychotherapy, antipsychiatric medicines may help. This is one of our patients with alopecia totalis. She is an 8-year-old child who is finding it difficult to go to school. Social anxiety and even frank depression at such a young age. Psychophysiological disorders are disorders precipitated by stress, anxiety, depression. As I showed earlier, role of stress is well established in many conditions like psoriasis, atopy, alopecia areata. Studies are there, well-controlled studies are there, and it cannot be discounted in others like vitiligo and acne. And flare-ups are associated in more than 30% cases. A stressful situation like exam causing atopic dermatitis is very, very common in our hospital. Most of the students come. Some quick cases here. I want, if possible, I want people who are there to tell me what this is. 36-year-old lady, after her brother's death, she has developed severe pruritus. Grief counseling done, psychotropics advised. She is better. Is it psychophysiologic or secondary psychiatric? It is psychophysiologic, something which has come with stress. This man, he's 72-year-old, severe intractable pruritus, dermatitis of thighs, which later became exfoliative dermatitis. He believes that his son and daughter-in-law is conducting black magic to cause the lesions. Daughter-in-law is a very prominent lady in his village. She has been in much controversies and they are almost pushing him out of the house. So his dermatitis has happened only after the conflicts. So this was a delusional disorder. His dermatitis was due to something else, but he's thinking that it is because of his daughter-in-law. Yeah, secondary for the first case, I think it was type. Usually, this worm crawling sensation, delusions all occur in older age group, but this was a youngster. He presented with severe itching. There was something underneath his skin. He had come to multiple people. So our initial diagnosis was confirmed. What is the diagnosis? And he was very resistant to treatment. Yeah, Ekbom's disease or delusion of parasitosis. He is now on aripiprazole. Multiple non-healing ulcers on her arms and legs. Sorry, I put it. Dermatitis artifacta. This is not my picture. This I took from the net. So this boy, he convinced his parents he had chicken pox. But unfortunately, it was only on the front of his abdomen and hands. This was a typical case of malingering. This was a chronic psoriatic case. He seemed well adjusted. Actually, he comes with a smile on his face. But one day, when we talked more to him, his psoriasis wasn't improving to treatment. When we started talking with him, he suddenly started weeping. Then we came to know his wife and son are sort of isolating him, asking him to eat separately, sleep separately, all that, thinking it's a contagious condition. So this is an example of secondary psychiatric. Psoriasis can very well be psychophysiologic also. This lady, HDLL with ENL with very low mood, dysthymia. And her ENL also gets precipitated whenever she is stressed out. So both psychophysiologic and secondary psychiatric. ENL is very well known to occur whenever there is stress. This lady developed lichen planus pigmentosus and now she is staying home, doesn't go out for any functions, including marriages. Secondary psychiatric. Inflammatory acne whenever she is stressed out. Psychophysiologic. So how to approach psychodermatological conditions? Characterize the conditions first. I said that up to 40% may have some stress or anxiety. Most of us do have. If I develop an illness, anxiety is natural. But see whether it is abnormal anxiety or not. And if you suspect something, just see whether you can treat on your own or psychiatry referral is needed. Try to familiarize with a few common drugs used in psychodermatology because most of the patients may not be willing to go to a psychiatrist. Treatment may be attempted for the minor conditions like mild anxiety, mild dysthymia, mild stress. Though some psychiatrists differ with us, when I talk to psychiatrists, they say it's better to refer all people because we may not be able to pick subtle clues. In case of severe depression, suicidal ideation, and if you feel they are not responding to your treatment, better refer to a psychiatrist. So what about case taking? Patience, empathy, forming a bond, gaining trust, all this is very important. Case taking should be in a quiet, calm place without any external disturbance. Observing the patient is important. Observe the patient, observe the people who have brought the patient, how they behave with each other. Prevent dominating bystanders. Usually it happens with younger people, many females being dominated by their husbands. So separate these dominating bystanders judiciously and with great tact. Ensure confidentiality. Don't ask about personal confidential questions initially. Take time to gain trust. Ask indirect questions first, like sleep, appetite, hobbies, absenteeism from work, headache, body ache, all that. Ask leading questions only when the patient is comfortable with you. It may be the first visit, it may be the second visit. Ask about the condition, whether it has caused any problem, ostracism, frustration, whether it is responding to treatment, and only slowly asked whether it has caused any humiliating incident. Try to differentiate between belief, delusion, and psychosis. For example, a patient may believe that chickenpox is due to Naga dosha, but if you say it is not, they may be ready to accept. Delusion is a fixed belief, like delusion of parasitosis. Psychosis, the patient is totally off track. What the patient says, you may not be trusting. Incomplete history, lack of history should be noted. And signs of distress while talking, the patient may be biting, fidgeting, scratching, wringing hands, may not be maintaining eye contact. So what is the principle of treating? Be familiar with 1 to 2 drugs from each group. Always start with low dose and know what are the side effects of the drug, very important. Look for drug interactions. Ask the patient what he or she is taking, and then only give your drugs. Especially in older patients, obese patients, you can't give mirtazapine or doxepine. Cardiac side effects are there. Slowly increase after 2 to 4 weeks. When in doubt, refer books, or better is make a psychiatrist your friend. Some useful drugs I talked in my previous slides, but still. So for dysthymia, SSRIs, OCD, higher doses required. Delusion, pymoside is not given nowadays. It's mostly risperidone, olanzapine, or erisperidone. Somatoform pain, it is amitriptyline, pregabalin. So this is the drugs mentioned in a flow chart. So tip, once again, I am emphasizing, familiarize yourself with 1 or 2 drugs. Be thorough about their contraindication and side effect too. So do no harm should be a policy. Primum non nocere. So I think I am done with my talk. Thank you once again.
It's a wonderful talk, and I think all of the students enjoyed your talk, and they have gained a lot of information from your talk. So for your participation and excellent talk, and I am sure that the dermatology trainees will have a good time. At least they will know what psychodermatology is and the license clinic and the importance of psychiatric consultation, and having a psychologist at hand. All these are stressed by you. Thank you very much. And to the students, psychodermatology is a very important and very worth pursuing in dermatology practice. And if you have a very good knowledge or very good command of psychodermatology, you may very easily make certain very important diagnosis without causing much of investigations. So thank you all the students for participating, and make sure that you learn psychodermatology in your training period. Thank you very much. Dr. Smitha, thank you very much for your lucid talk. Thank you once again. Thank you.
Thank you, Doctor. Ishas Sharma extends my cordial gratitude to Dr. Smitha Prabhu, ma'am, to has given wonderful session, and our PGs also will benefit out of the session, madam. And also, Ishas Sharma extend our gratitude to Dr. Ketan sir to continuously doing this educational program for the benefit of the PGs for the past 2 years. So the same way, Ishas Sharma always committed for the academic sessions. So my request to all PGs to share the details for the forthcoming sessions also to your colleagues, and let them also be benefited. And Ishas Sharma wishes you advance happy Diwali to all. Thank you, Doctor.